speaker. Dr. Mark Elliott is a clinical assistant professor, newly started at University of British Columbia and practicing based at St. Paul's Hospital in Vancouver. He has a clinical and research interest in the genetics of kidney disease and uses genetic data to improve and is imparting the use of genetic data to improve and inform care. He hails from University of Calgary, where he did his nephrology training, and then did a 2-year fellowship in precision medicine and genetics of kidney disease at Columbia University in New York. And there he focused on clinical outcomes of patients with genetic kidney disorders. So we're really thrilled to have him as a resource to the province with his expertise in genetics and nephrology. And so with that, Mark, welcome both to the province and to province-wide rounds. Over to you.
Great, thanks so much. Okay, great. I'm presuming that worked. So yeah, thank you so much for the kind introduction. It's really an honor to be here today. And I'm really excited to present our first province-wide rounds of the year. So as Adira said, my main research interest is in the genetics of kidney disease, and so that's what I'm hoping to talk to you about today. So I have some honoraria to disclose, but they aren't material to today's talk. So what I'm hoping that we'll get out of this session is that us as nephrologists will be better able to identify our patients who are at risk of genetic kidney disorders. This is really important because, as we'll talk about, there are significant implications for the clinical care of our patients living with kidney disease if we're able to identify a genetic underpinning for what's going on. I'm hoping that I'll sort of present an unmet need that exists within British Columbia to make it easier for us and our patients to have access to genetic testing. And then I'd like to highlight a clinic that we're putting together that's going to help all of us to get sort of better answers for what's going on for our patients by making it easier to get access to genetic testing. With that, I wanted to start off by talking about the genetic landscape of kidney disease. And I really like this figure because it highlights a couple of things. The first is that in the top left, we can see a group of disorders caused by really, really rare alleles. So these are changes in our DNA that are present in usually less than 1 in 10 or less than 1 in 100,000 people. And oftentimes these changes are actually unique to a specific family. They have a really large effect. So these are our classical ideas of monogenic kidney disorders, or when you hear genetic kidney disease, this is what most people think about. Things like our collagenopathy genes or polycystic kidney disease. I really like this figure because I think it highlights the significant overlap between the different phenotypes that exist both within specific genes. So if we take PAX2, for instance, we can see that it causes FSGS as well as CACUT, but it also shows significant phenotypic variability within certain specific genes. So it makes it really tough to select either a single small panel because the phenotypes overlap quite a bit, and oftentimes they have to be quite broad because the genes themselves can have many different impacts in our patients. On the other end of the spectrum, we've got our common alleles that are quite prevalent in the population, usually at a frequency of more than 1%, that individually have very small effect sizes. But if we take them together, we can get a better idea of what a patient's risk of developing a common condition like chronic kidney disease could be. These can also inform patients' eGFRs as well as their levels of proteinuria. In nephrology, we've got a couple of very interesting genetic outliers as well, including FSG or APOL1, which is actually quite common in certain populations because of its sort of positive evolutionary selection due to protection from African sleeping sickness, but comes with the significant downside of significantly increasing patients' risk of developing, especially interferon-mediated FSGS. There's also a very interesting common variant interaction that happens in membranous nephropathy between our HLA type and our PLA2R receptor loci, which actually has a synergistic effect, leading to a really outsized effect compared to how common these variants are. So I think in the future, we're going to see more and more of these common variants start to get integrated into clinical care in a meaningful way. From that, I'd like to focus on monogenic diseases to start because that's where most of the research has been done so far and sort of what we have access to clinically at this time. Still, the seminal paper in genetic testing for patients with kidney disease came out of the group at Columbia who I worked with in 2019. And they studied 3,300 individuals who had chronic kidney disease of a variety of causes, including about 2,200 patients from Colombia and 1,100 patients from the Aurora trial, which looked at statins in dialysis patients. They performed whole exome sequencing for these patients and identified a significant diagnostic yield for the overall population of just over 9%. So these patients were typically not fully diagnosed without their genetics, and so this significantly improved sort of the answers as to what was going on for these patients. If we looked at the specific phenotypes that had the biggest yields, it was congenital and cystic kidney disease, which we would sort of expect. We know pediatric disease is more likely to be genetic, and we know that polycystic kidney disease is the most sort of typically common genetic form of kidney disease, so that makes sense. But interestingly, nephropathy of unknown etiology and glomerular diseases also had a significant yield from this study. And that's a finding that's been replicated in a lot of diagnostic studies that have been done since then. But the clinical phenotype is only part of the picture. And I want to highlight a couple other clinical features that are really important. These include the presence of extrarenal manifestations. So these can be things like cognitive abnormalities, congenital heart disease, seizure disorders, or other visceral changes or structural abnormalities that we note. But it can also be things that are more specific for a given syndrome. So lenticonus and deafness points us to Alport syndrome. Like patellar problems and no nails points us to nail patella syndrome. So some of these extrarenal features can actually be quite specific for individual disorders. The age at onset, as I said, matters. So the younger a patient is when their disease started, the more likely it is to be genetic. And then having a family history of kidney disease is obviously going to increase your risk of carrying a genetic cause. So putting these all together, we end up with quite a drastic difference in the diagnostic yield based on a patient's phenotype. And what this tells me is that we can adjust the diagnostic yield of our testing in order to optimize its efficiency by trying to select those patients who have these high-risk features. And so as part of the work that I'll present later, this is something that I've taken into account in trying to figure out how we can best test patients. When we actually do the testing, though, we actually see a very interesting distribution of our diagnoses. So this is looking at two different studies. The top one is that same New England Journal paper, and it just breaks down the number of positive variants identified based on the gene that's affected. And what we can see is a typical pattern that exists if you do this in almost any published paper, where there's a cluster of common genetic diagnoses, which will include autosomal dominant polycystic kidney disease, our collagenopathies, and then our other common forms of FSGS, like TRPC6 and inverted Foreman 2. But then there's this long tail of genetic diagnoses, which make up a group of ultra-rare disorders that are usually never going to be diagnosed in these patients in the absence of genetic testing. And although the peaks are much lower, what's interesting is when you take all of these rare disorders diagnosed together, they actually make up a significant proportion of the positive findings from any of these diagnostic studies. So again, in the New England Journal population, it was just over a third of the cases came from this long tail. This again suggests to us that we really need to be cognizant of the genes we're testing, because if we narrow our testing panels too closely, we may be missing out on positive findings because we're not checking the right genes. So this makes ordering testing in nephrology a bit more complicated than it is in other specialties where they don't have this significant heterogeneity and this long tail. One of the things you might be thinking is, that's great, Mark, we can diagnose these patients, but genetic kidney diseases are sort of just there. We don't have a lot of specific therapies for them. Why are we caring about this? Why does it matter for our patients? And the reason it matters is a couple-fold. First off, a number of these patients have an incorrect diagnosis based on their previous workup. So if we take these three categories together, these are the patients where there was some diagnostic clarity that was gained by genetic testing. It occurred in over 70% of the population. So that to me is really meaningful. We can tell 70% of the patients we see at the clinic who have a positive test that we actually have a new diagnosis for them. That's going to matter to them, and it should matter to us. The other thing that I'd like to highlight is that in almost 80% of the patients who gained a molecular diagnosis here, there was some impact on clinical care. So that could be stopping medications that we know are not effective, starting new medications that we think will be effective, altering their screening, which is especially important for those non-kidney related manifestations. And it also can impact their family planning and family screening. So there are significant clinical impacts for patients. This was all based on retrospective data, so it's maybe not the best, but we do also have prospective data now that shows almost the exact same diagnostic or clinical yield of genetic testing. So this study looked at 80 families who had positive genetic findings, again, a variety of different kidney disorders, and looked at the prospectively at the clinical utility of these findings. And what they found is that for patients and their families, over 90% of those groups did have some positive outcome or some change that occurred because of their genetic testing. And it's not small changes, like 10% of this population, which was only 80 families, were allowed to forego a kidney biopsy with all the stress and risk that comes along with it, just because they had genetic testing done beforehand. 35 patients had their extrarenal surveillance changed, and 16 patients had their treatments directly changed. So this is really meaningful for our patients and leads to significant changes for them. To the point where there was recently a controversies conference put together by KDIGO that really tried to get people together to put their heads together and think about what sort of actionable ideas do we have coming out of genetics in nephrology. So there are certain lists that have been put together with actionable genes in other fields. So the ACMG, or the American College of Medical Genetics, has put together a list of what it thinks are generally actionable findings from anyone who's getting whole exome or whole genome sequencing. That typically includes cancer-causing genes and sort of cardiac arrhythmia genes, where we have treatments and they're often life-threatening. So this group tried to put together a list of actionable kidney-related findings. And I think it's a nice presentation of all the different ways that genetic testing can have an impact on patient care, ranging from disease-specific therapies like enzyme replacement therapy for Fabry's or coenzyme Q10 supplementation for certain types of genetic FSGS, to discontinuing therapies that we know are not going to be effective, to impacting kidney transplantation decision-making, and obviously family counseling and reproductive counseling. So this really runs the gamut. And to give you an idea, like Miriam and I were seeing a patient at the Polycystic Kidney Disease Clinic just this week, or just last week, and this patient has polycystic kidney disease, although it's not that bad, has diabetes and has some cognitive changes. And so when we think about certain constellations of symptoms, that is similar to what an HNF1 beta variant could do, which gives the patient a very different prognosis than a PKD1 or PKD2 variant. So these extrarenal manifestations really do come into play and are really clinically meaningful as well. To me, the last real key that says we really should be pushing for genetic testing for our patients is if you talk to our patients, they really want it. And there's been sort of perspective after perspective after perspective after perspective published in the last few years that are patients really trying to speak up and advocate for access to genetic testing. They understand that it's not going to give every single patient an answer to what's going on, and they understand the limitations of what it can offer. But despite that, having the answer as to what's going on in their kidney troubles and all the other ancillary benefits that come along with a molecular diagnosis are something our patients really push for. And if you want just a heart-wrenching read on this beautiful Friday afternoon, the paper by Lisa Bonebrake from the Alport Foundation of Scottsdale is really just a heart-wrenching journey that a family takes through a diagnosis of Alport syndrome. And if you want to remind yourself that the way we communicate and our understanding of these rare diseases matters, this is a great example as to why we really need to stay up to date about things and really need to be careful about the way we talk to our patients and go about diagnosing. So all really good reads, but that one really stood out to me. So when I first came to British Columbia, one of my goals was really to make it easier for everyone to have access to genetic testing. And to try to figure out why that wasn't the case, I met with a lot of different players and a lot of different stakeholders within the health system to try to find out what our barriers to genetic testing are. Because in the US, it was actually very easy to order. It was relatively inexpensive. Most insurances were covering it, and it was very easy. I learned that it is relatively easy here, but there's quite a few barriers that make it difficult for us as sort of very busy clinical nephrologists to order genetic testing for our patients. One of the key limitations that I've seen so far is that most people will get their genetic testing done through medical genetics, which is a great service. You see a genetic counselor, there's medical genetics expertise, but the trouble with this service is it takes a long time to get it done. So oftentimes the waits to see medical genetics are 1 to 2 years, and that's just to get your foot in the door for your first visit. That isn't to get testing done, and that isn't to get your results returned. So oftentimes those other steps add at least 5 more months to the process, meaning that our patients are waiting up to 1.5 years, 2.5 years before they get their genetic testing done and come to a final diagnosis. This really limits our clinical utility of these results in a lot of cases. Like if you have a patient with steroid-resistant FSGS and you're wondering what you should do next, knowing in 1.5 years or 2.5 years just isn't good enough. And so having an option that's faster than this, that gives our patients the results they want quicker, is going to be really helpful. The other thing that I've noticed is that the way that the current testing paradigm is set up, mostly driven by medical genetics, is that these genetics reports don't actually get captured systematically anywhere. They don't keep a database of who's been tested and what the findings are. And so this data that would be very, very important for a lot of different research questions really isn't systematically captured. And I think that's a big loss. The other sort of barrier that I saw was that most of us as nephrologists and most of our trainees also do not feel comfortable ordering and especially interpreting genetic testing. So lots of us have never ordered genetic testing before. Most of us received almost no training about the genetics of kidney disease at any point of our careers, beyond sort of maybe the basics of autosomal dominant polycystic kidney disease. And those of us who have ordered testing in British Columbia recognize that the testing logistics are very complicated and very time consuming. Just filling in the forms for your out-of-province funding, then you have to order the test, you have to follow up on everything to get your patient set up, then you have to finally get your results. Probably takes 30 to 60 minutes just to do the paperwork for each patient. So that's a prohibitive amount of time to have to spend on this for someone who's in a busy clinical environment. But having said that, when you survey and talk to nephrologists, everyone is so excited to have this available. We really recognize the benefit that it brings to our patients. There's just all these barriers that make it difficult to access. And really, when I thought about this and looked at the literature, British Columbia is not alone. So this was a study of almost 150 practitioners in the US who provide nephrology care, and included people who frequently use genetic testing within their practice and those who don't use it. What we can see is that even in the people who use genetic testing frequently in their practice, a significant number of them reported significant or highly significant barriers to genetic testing, suggesting that there's still a lot that we have to do to make this easier. The most kind of common reasons that these providers recognized as barriers were the cost of testing, which I think here at least is not an issue, which is nice. The availability and ease of testing, so I think this is one of our key areas as I spoke about, and then lack of access to genetic experts. And I think this is sort of how the time issue that I had presented earlier was framed for this. So, I mean, you clearly have a lack of genetics expertise if it takes you 2 years to see a genetics expert. So if we can remedy some of these issues, then hopefully we can remove the barriers and get our patients access to testing. They then surveyed the same respondents about what things would help them to overcome these barriers, and they broke it down into 3 key themes. The first was resources to help make it easier. And for me, I think the biggest one that stands out is really providing the results in a way that's detailed enough and includes the implications for our patients and their family in a way that's sort of understandable and readable for us as nephrologists. So that is certainly one of the goals that I have, making the ordering process easier. I wish I had a good answer for this. I've tried my best to make it as easy, but it seems like this one isn't going to change, at least in the near future. The other places where I think we can make a big difference is for educational resources for us as physicians and nurses working in KCCs or dietitians sort of across the spectrum, is to provide us with educational resources to better understand our patients' conditions and understand what they're going through and some of the nuances that exist, but also to create educational resources for our patients. So pamphlets talking about what genetic testing is, sort of easy to understand and easy to use, things that we can give patients and help to talk about what Alport syndrome is, what some of these other genetic conditions are, would be really helpful for our patients. And I think that would be another goal for a provincial program to try to develop some of these resources to make it easier for our patients. So in thinking about ways that we can sort of deal with these barriers and get our patients what they need, there's a couple of models that have been tried out in different health systems throughout the world. But the one that I thought was going to work best with our needs was to develop a multidisciplinary kidney genetics clinic that's led by nephrology, but integrates both clinical genetic counselors as well as our medical genetics colleagues, so that it can serve as a center of excellence for our patients who have genetic kidney disorders or who we think could have genetic kidney disorders. It will be physically located at St. Paul's because that's where I'm physically located, but thanks to virtual care and the flexibility of genetic testing, it will be provincially accessible and equitably accessible. The reason I bring this up is that we're able to do genetic testing through saliva testing in almost all cases now, which makes it really easy for the patients. The saliva test gets sent directly to them, they do it at home, and then they send it directly back to the company who's doing the sequencing. So it makes for a very easy process that can be virtualized and accessible anywhere that has mail service. The other goals of the clinic were to integrate educational, research, and clinical activities in one space. So anything that gets done clinically, we're trying to capture the information that gets produced so that we can use it for education and research going forward. And so it was really designed from the ground up with these principles in mind. To give you an idea of sort of how I think how it's structured, really the patients and their families and the clinical care that we provide is at the core of this clinical experience. We add on a research component, which includes working with the PROMIS team so that we can actually capture genetic testing results in a meaningful way so that they can be searchable and useful in the future for future work. As a sort of next project for me, starting to collect raw genetic data for our patients so we can sort of work on some of those more exploratory research questions that we have and really push this field forward and get us involved in national, international consortiums that I think we really could contribute quite a bit to. The next thing I think is important to integrate is clinical trials. And although we're sort of just at the forefront of developing medications for these rare genetic kidney diseases, every year there's many new trials coming out with targeted therapies. So in the future, it's going to be really important, again, to use that data collection piece to help identify patients who might be eligible for clinical trials or for new therapeutics as they come onto the market. Education is a very key point of this. So both through continuing medical education events like these province-wide rounds, but also through having fellows rotate through the clinic, education of our allied health members through sort of other initiatives province-wide, and for sort of our medical students and our patients. I'm really hoping that this can serve as a place where we can spread a lot of educational experience, but also develop those province-wide resources that are going to be very helpful for everyone. And then there's a technologic piece of this. So obviously genetic data is very large. It takes sort of an infrastructure on the back end, and I'm working to get that set up as well as hoping to integrate some newer technologies like deep phenotyping and some patient-reported outcomes for all of this. So in the end, I'm hoping we'll have a very holistic way to care for our patients with genetic kidney diseases that allows us to integrate these different fields. In terms of what a patient's journey through this sort of clinical experience will look like, it'll start with one of you or myself identifying a patient who we think could have a genetic kidney disorder. And I've sort of put together a sheet that'll help us to identify these patients in an easier way. At that point, you'll refer your patient to the genetic kidney disease clinic, and we'll meet with them for the first time for their pre-test visit. What we do at this visit is we talk about genetic testing, we review their medical history, and then we talk about the different outcomes that can happen and decide with the patient whether they think genetic testing is something they would be interested in or not, and also whether it's going to be something that's going to be beneficial for them or not. If after all of this, we decide that we're not going to pursue testing, their care will be referred to their nephrologist with a note outlining why we didn't decide to do testing. So it's sort of a similar model to how the glomerular disease network or the glomerular disease clinic operates for those sort of one-off questions. If a patient does get testing, then we set up a second visit with them where we return their results and talk to them about how we can integrate this into their care as well as into their family's care. And based on this, we might end up testing family members. So we may obviously bring them back into clinic a couple of times to get sort of all of the extra testing done. But really the goal of this return of results visit is to tell the patient what's going on and to come up with a plan of things that we can sort of implement into their clinical care. Because it's a distributed model that's provincially available, I'm going to leave the actual sort of carrying out of those recommendations to their primary nephrologist, because the way to access different sort of screening or different referrals is very different in different places of the province. So what we're going to create is sort of a recommendations of what we think the best way to integrate this into a patient's care is. And I'm going to leave that in the hands of us as general nephrologists, not the kidney genetics clinic, to implement those. So the goal here is that we can be really efficient with the clinic's time to try to get as many patients tested as possible, while also providing these patient-specific recommendations in order to optimize their care. And when I spoke earlier about the patients who I think are going to have the highest yield, I put them into a relatively easy to check off spreadsheet here. So this is part of the referral form. I'm hoping it'll get a bit prettier going forward, but the idea here is you can just check off whichever phenotype your patient has, and those are the cases who are most likely to have genetic diagnoses and are the most reasonable people to see in the clinic. There's obviously an other section at the bottom, so if you have something else that's not included here that you think is important to include, please refer those people and I can take a look at the case and we can decide whether we think that genetic testing is beneficial or not, or even just see them and decide in person if there's something that's very strange going on. So these are the patients I'm really hoping to see, and we're going to have a reasonable diagnostic yield from. I worked with the PROMIS team to pull the sort of the demographics and the diagnoses of our patients who are currently followed in KCCs throughout the province. And just based on their phenotypes, because we don't capture things like parental consanguinity or family history of kidney disease within PROMIS, there's probably about 2,400 patients who could be seen by the kidney genetics clinic. And based on those specific phenotypic breakdowns, I think there's probably about at least 400 individuals in our kidney care clinics who have genetic diagnoses who we haven't identified yet. And you'll notice that there's a clear disease that's missing from this list, and that's autosomal dominant polycystic kidney disease. And so I haven't actually included that in these numbers and haven't included it in this clinical goal, because we already have a well-developed network for autosomal dominant polycystic kidney disease, and there's already a streamlined way to order testing for that disorder. And so I really am not hoping to see those patients in the kidney genetics clinic, because we already have something else that works really well for those patients. So from there, I wanted to take a bit of a pivot and talk about sort of the different outcomes of testing that I talk to patients about when I'm actually in the clinic with them. So when they ask, well, why should I get genetic testing? These are the few things that I always talk to them about. So to me, there's sort of 4 clear outcomes of genetic testing. It can provide you with a clear molecular diagnosis, which can be really helpful for patients. And as I said, is something that they really push for. Oftentimes they cite this is the most important part of it, is just having a clear understanding as to what's going on. It can provide us with significant prognostic information for our patients to better understand what their journey with kidney disease is going to look like. Obviously, it can inform family planning and familial risks, and then it guides treatment and transplant decision making as well. And this is sort of just at its earliest stage, and I think is going to really expand going forward. So I just wanted to give a couple examples of each. So in terms of getting a clear diagnosis, I wanted to present a case who I saw in Colombia. So due to the fragmentation of the US health system, oftentimes patients are followed at multiple different centers for multiple different things. And so this was a patient who came to Colombia really just for her nephrology care. She was 21 years old. She developed new onset hypertension, and in the secondary workup, her primary care provider identified proteinuria for her with a preserved eGFR. So she was referred over to us at Columbia and was seen by our glomerular center, where she had sort of our standard secondary workup for FSGS done, which didn't show anything. Because we weren't clear what was going on and because she's so young, a kidney biopsy was pursued. And here is one of her glomeruli, which shows a lesion of FSGS. And this was just one representative glomeruli, but she had pretty reasonable FSGS at this point, with focal foot process effacement, normal-looking glomerular basement membranes, and no clear secondary features. So there wasn't glomerulomegaly. There wasn't really anything to point us to a specific diagnosis of FSGS. Based on this, she was treated with RAS inhibition and had a good reduction in her proteinuria. but then became pregnant, and a couple years later experienced preeclampsia, leading to an induction, but she had a term birth that really wasn't complicated beyond the preeclampsia. Unfortunately, following that, she was left with worsening hypertension, and so we had to add on extra medications on top of her RAS inhibition. At this point, she didn't come back to Columbia for her care. She was moving and moved somewhere else, but she came back to us in sort of a roundabout way. A couple of years later, she booked a follow-up appointment with the clinic and asked a really good question. She had just sent her daughter for sort of routine testing, and it was identified that her daughter also had proteinuria. And so she thought, well, I have proteinuria, my daughter has proteinuria. Could these be linked? And it also got her wondering, well, what is really the cause of my kidney disease? Like, you've told me I have FSGS, but no one was able to give me a good answer as to what's going on. It's been 4 years, I've seen multiple different providers, and I really don't have a clear answer. And this is a really good description of something called the diagnostic odyssey. And the idea of a diagnostic odyssey really exists for rare pediatric conditions first and foremost. But I think our patients in nephrology also often experience this diagnostic odyssey, especially with these non-specific diagnoses like FSGS, or you've got a chronic interstitial nephritis that really you don't have a good answer to. This is the idea that rare disorders are often very difficult to diagnose. They take a long time. So in this infographic from a certain study, it took 7 years for most patients to get a diagnosis. They saw 8 different specialists throughout the way, and oftentimes had many different invasive tests. So biopsies of different organs, surgeries for different things. And ultimately, just over 40% ended up with an incorrect diagnosis when it was further clarified when they finally received genetic testing. So really the paradigm, if you read any of the literature on diagnostic odysseys in the last few years, is that we should really be pushing a genetics early approach for these patients with difficult to diagnose or unknown etiologies of diseases. And I think FSGS, CKD of unknown etiology, and maybe some of our patients who get diagnosed with hypertensive nephrosclerosis without the most striking hypertension are probably patients that are on a diagnostic odyssey of their own. So being at the kidney genetics clinic, we obviously ordered genetic testing for this patient. We ordered a standard panel that includes all of our FSGS genes, and we were able to diagnose her or to identify a pathogenic variant in PAX2. Now, PAX2 gene, as you may or may not know, is associated with 2 different conditions. So the first is renal coloboma syndrome, which involves optic nerve involvement, deafness, as well as caput. So structural abnormalities of the kidney and urinary tract, as well as isolated FSGS. So she appeared to have a phenotype that fit with the second one. And when we did segregation testing in her daughter was also affected. So this was a very clear example of how we were able to end her diagnostic odyssey, but also to impact her daughter's care as well. Because we recognize that these are genetic forms of kidney disease, we can alter our therapies to be appropriate for that, as well as to help her with any future pregnancy planning that may come up. One other place where I think the diagnostic piece is really, really important is when looking at our patients who are waiting for kidney transplants. So this was an interesting study that took a group of patients who were on a transplant wait list but were yet to be transplanted. And they looked through that group for individuals who they thought had a higher risk than average of having genetic kidney diseases. So whether that was their phenotype, a family history, or some sort of extrarenal manifestation that had been identified. And they found 115 individuals who they thought might qualify. They then performed exome sequencing in these patients, and what they were able to do is very similar to the previous studies we've looked at. In 29 of these families, they were able to reclassify and correct the primary diagnosis, with again, the majority of these patients having Alport syndrome or a genetic form of FSGS. But some of them had very treatable forms of kidney disease, such as Fabry's disease, which hadn't been previously recognized. So again, really meaningful impacts in terms of patient care. The other thing that they did was really interesting, which is because they had exome sequence data, they were able to look at those ACMG secondary findings, which is our cancer predisposition syndromes and a lot of cardiac abnormalities. And they were able to find a secondary finding in 4.4% of this population. And especially peri-transplant, this can have a really big impact. So congenital arrhythmias could be really important in the perioperative setting. understanding a patient's risk of hereditary cancer predisposition could play a significant role in choosing or adjusting immunosuppressive medication. So we don't have a lot of prospective work on this at this point, although I know Columbia is running a study right now that's looking specifically at this. But I think we're going to start to see it play more and more of a role in our patients who are pending kidney transplant. The next thing that I wanted to talk about was how we can use genetic information for prognostication for our patients. And this one I sort of see as an onion. So there's different layers that we can go into in terms of how we use the genetic data and which genetic data that we use. Starting with our sort of broadest interpretation, which is using a polygenic risk, moving down to more integrated analyses that take into account our whole genetic landscape. So rare variants, common variants, as well as clinical features to give our patients a really good understanding of what their journey is going to look like. So starting with polygenic risk, I've really focused on monogenic forms of kidney disease so far. But polygenic risk is really being used quite frequently for common conditions as well. And so CKD being a common condition fits well for the needs of these sort of tools. So what this does is it takes all those common variants that all of us have, ranging from hundreds of different variants to millions of different variants, each with a very small protective or harmful risk, and it integrates them over the sum of your entire genome. So what it allows us to do is identify people who have an increased number of protective variants, which is like our patient on the left here. They're at lower risk than the average person of developing a condition based on their polygenic risk. Or it can identify patients who have a lot of those harmful variants, placing someone on the right of our curve at an increased risk compared to the average person. And what we can do then is bucket people and then try to figure what their risk is going forward and hopefully intervene on that. This publication from last year is probably the biggest and best polygenic risk score that's been developed for CKD. It used a number of different data sources, but aimed at identifying individuals with a GFR less than 60. And what we can see on the left is that as you increase your quantile of your polygenic risk, your risk of kidney disease goes up. They also integrated APOL1 risk into this, which adds an entire standard deviation to the curve. And so you can see your APOL1 risk increases your overall risk of developing CKD. What's nice about this study is they actually used a multi-ancestry derivation population and then validated it in that cohort as well. And so we can see that it performs quite well across the different ancestry groups, which is not true of polygenic risk scores that are developed in only a single ancestry population, where they often don't actually apply well to other groups. There's a really interesting sort of stepped risk. So the top 5% have a lower risk than the top 2%, which has a lower risk than the top 1%, which is exactly what we'd hope to see. Additionally, a top 1% has a risk of about 5-fold. So these patients are actually at significantly increased risk of developing kidney disease in their lifetime. And this may be something that we're able to sort of address going forward. This is exactly the question that's being asked in the eMERGE study, which is going on in the US. And one of the parts of eMERGE that's currently happening is a prospective evaluation of 25,000 individuals who are undergoing an integrated genetic and clinical evaluation to better understand their risk of common conditions. And they're doing this for 10 diseases, of which CKD is one of them. Unfortunately for CKD, we don't have an integrated evaluation tool yet. And so it only returns the polygenic risk for our patients. But what's created is a profile report card, so it identifies an individual as high risk. And then there's screening and health behavior recommendations that are made in order to hopefully reduce that patient's risk of developing CKD in the future. And as I said, it's prospective, and so they're really looking at disease-specific outcomes in this. And we don't have that data yet, but I'm hoping in the next few years they'll start to be able to develop it, because I think they're most of the way done the sequencing part of the study. In terms of what they're actually offering patients who are identified at high risk of having CKD, it's checking a creatinine and a urinalysis to look at kidney function and for albuminuria, checking your blood pressure as well as the hemoglobin A1C for your cardiovascular risk reduction or risk factors, and then just generally emphasizing a healthy lifestyle with all the typical lifestyle recommendations we would make for any patient with kidney disease. So I'm interested to see if this is going to be positive, because it really would sort of change the paradigm and move things towards more of a preventative angle as well as just a treatment angle. There's then the impact of the monogenic findings that we talked about earlier, and I'm sorry that I can't present this data because it's been submitted for publication but not accepted yet, but there's a lot of emerging data that shows that patients with monogenic kidney diseases have a worse prognosis than those patients without. So they're going to reach end-stage kidney disease earlier, they have a faster loss of eGFR over time, and just generally do worse than those patients who don't have a monogenic form of kidney disease. This is really important for our patients to understand what their journey is going to look like, but also if we're trying to design clinical trials, because an imbalance in the proportion of patients with monogenic kidney disorders could skew a trial either towards positive or negative, depending on which group is skewed. We know that there's a significant impact of APOL1 on patient outcomes. So we saw it earlier in our polygenic risk score. Here is looking at kidney survival in the FSGS study. So this is the one that used mycophenolate versus cyclosporin, and individuals with 2 risk alleles reached kidney failure much earlier than those with 0 or 1. And there's been many studies that have shown a faster eGFR decline rate in individuals with high-risk APOL1 genotype. So again, this helps us to understand what our patient's journey is going to look like. There's also new data that's coming out that's suggesting having a family history of kidney disease increases your risk of progression, which might be a surrogate for any of our genetic causes. So whether that's our polygenic risk, or whether it's a family that's carrying an unidentified monogenic form of kidney disease, I think it's a really interesting question to bring up. And one of the things I've always wondered about is, especially for IgA, where we know we can identify collagen variants in familial IgA, if that's part of what's driving these differences in outcomes. Beyond just having a monogenic diagnosis, though, there's lots of specific genetic features that we know are important for our patients as well and can help us to figure out exactly what their risk is going to be. And probably the most striking one here is going to be our variants within autosomal dominant polycystic kidney disease, where we know that PKD2 variants are more mild than PKD1, and that truncating PKD1 variants are more severe than non-truncating ones. So just based on understanding a patient's genetic variants, we can understand what their journey with polycystic kidney disease is going to look like. This is also true for other genetic conditions, although we've got smaller populations, and so it's been difficult to really verify these genotype-phenotype correlations. With things like Alport syndrome, this exists, as well as in ARPKV, where your variant type, but also where in the protein a missense variant occurs, both have a significant impact on what a patient's journey is going to look like. So that really, as we get larger cohorts, I'm hoping that these specific features become more and more clinically useful. Lastly, I did want to touch on integrative analyses because they're starting to be developed. And this is a really interesting paper that's a preprint, again, from the same author that made the polygenic risk score for CKD. And what he did was he used the All of Us database as well as the UK Biobank and identified patients or people within those groups who had either polycystic kidney disease variants or a collagenopathy variant, and then also calculated their polygenic risk score. And we can see that the polygenic risk score works quite well within the cohort, but he didn't identify an interaction between the two. So it doesn't look like there's anything beyond an additive effect for these two models. But it does give us a clear answer as to there are differences between sort of someone with a high-risk PRS and someone with a low-risk PRS and a collagenopathy variant. So this might help us to understand a lot of the heterogeneity we see in the clinical outcomes of patients with kidney disease. So I'm really excited for this to get sort of a bit more developed, and also really excited for them to start integrating clinical features as well. From there, I just wanted to conclude by talking about how this can change our patient treatments. So we talked about sort of the EMERGE study looking at lifestyle changes. And for me, when I think of our treatment pyramid, these are the basis that we should be doing for all of our patients, pretty much no matter what. On top of that, we add on non-specific therapies. So these are things like RAS inhibitors and SGLT2 inhibitors that help to reduce the progression of CKD in most cases. Beyond that, we have targeted therapies. So these are things like immunosuppression and autoimmune-mediated glomerular disease, things like 12-aptan for ADPKD, where we're starting to get at a molecular basis of therapy and hoping to improve sort of a more basic level what's going on. But really the goal of therapy, I think, for medicine should be to cure our patients. We haven't had it as an option forever, but with these understandings of molecular disease, we're getting to the point where we're starting to see curative therapies become available. And so this is really exciting, but really changes our treatment paradigm and makes it really, really important to get our diagnoses right. So I'm just going to focus on a couple examples of these as we conclude. So for those of us that were at ASN last year and also have read the New England in the last year, there was a really interesting paper published about a small molecule APOL1 inhibitor. They started off with a cell culture model where they showed that APOL1 has a pore-like activity that allows thallium to move in and out of cells, and that this was blocked by their small molecule. They then used a mouse model, which we can see at the bottom. So it was a G2 high-risk APOL1 genotype mouse model that was induced by interferon. And they noticed that the small molecule significantly reduced the albuminuria of these mice. Just as a side note, APOL1 mice models are really interesting because the mice don't have APOL1. And so it makes it sort of a very complicated problem to sort out. They then used this small molecule in 16 individuals with biopsy-proven FSGS, and they were able to show that there was a significant reduction in the urine protein to creatinine ratio for almost all of the individual participants, with an almost 50% reduction in their proteinuria at week 13 of therapy. So to me, this is really exciting. This was just phase 2 data, but the phase 3 trial is currently recruiting and ongoing. And so I think this would really be nice to have an option that's targeted for patients with APOL1, because most of our standard therapies for these patients really leave a lot to be wanted. I think one of the most interesting figures from this study, though, was hidden in the supplement. And this was a washout that was done for 9 individuals where they stopped treatment and followed the urine albumin to protein to creatinine ratio over the next 3 months. And what they saw was that this protein to creatinine ratio didn't return exactly to baseline. There was a persistent reduction that went forward. So this to me suggests that we maybe have altered the way that the podocytes have behaved, maybe we've saved some of them, and so we've hopefully improved the patient's outcomes for a longer period of time that we've treated them for. But again, this is early study with just a few patients, and so I'm really looking forward to the bigger cohorts to help figure this out a bit better. The last thing I wanted to talk about was, I think, a very exciting piece, which is gene therapy, and we're starting to see gene therapy available for kidney disorders. So this was a Canadian study. It took 5 men who had classic Fabry's disease, who were stable on enzyme replacement therapy, and did ex vivo gene therapy. So they donated, or they had a collection of their bone marrow cells. Those cells underwent a transfection, and then they went an autologous stem cell transplant with those white blood cells that had undergone gene therapy, with the goal of curing their Fabry's disease. And I've included the construct in the top part here, so you can see it's got a codon optimized alpha-galactosidase A in the middle, and then it's got a bunch of things built into it to help prevent sort of activation of oncogenes and other adverse effects that we know some of these gene therapies can cause. And they have a reasonable amount of follow-up for some of these patients at this point. And what I'd really like to highlight is 2 things. So first off, there was a significant increase in their endogenous alpha-galactosidase activity in all of the patients. One of them, patient 3, never restarted his enzyme replacement therapy. So he had reasonable control of his lyso-G3V, as well as stabilization of his EGFR, completely off enzyme replacement therapy. And 2 of the other patients were able to stop at some point along their journey. So patient 4 and patient 1, again, all with relative stability of their clinical parameters. So to me, this is really exciting because enzyme replacement therapy is really cumbersome and burdensome for our patients. It's very expensive, and offering them a one-time gene therapy with a curative intent really could change the paradigm for treatment in Fabry's disease. So I'm really hoping that we have this available for more conditions going forward as well. So with that, I just wanted to conclude with highlighting again, the genetic kidney diseases are common. They're mostly undiagnosed or underdiagnosed, so we really do need to think about them. It's very important for our patients to diagnose these because they want to know, and they have significant impacts on their clinical care. Genetic testing is underutilized, and I'm really hoping the Kidney Genetics Clinic can help fix that and really get our patients easier and better access to testing. And so it's open to referrals, and I'll work with Adira to figure out the best way to get a referral form out to everyone throughout the province so that we can start seeing your patients and getting them tested. So thank you so much for your time and attention, and I'm happy to take any questions.
Thanks, Mark. Maybe we can stop sharing and we'll make it a little bit easier to see the screen. So that was excellent and a fantastic overview, and I think brings yet more excitement to the sphere of nephrology and all the things that we can possibly offer people. There's a great question from David in the chat. Do you see a role for assessing polygenic risk for young individuals who are getting worked up as living donors, whether it's recipients who are related or non-related? And might that be another thing, and how many people have explored that in this context?
Yeah, so I'm not aware of anyone who's explored it in sort of a systematic way, but certainly one of our tenets of living transplantation especially is that we want to do no harm to our donors. So if we can give them a better tool that helps to prognosticate what their risk of CKD is going to look like in 5 or 10 years, and it includes some polygenic risk, I think it's going to be something that we'll do. Like, we're going to get to the point where people have their genetic data and they're going to ask us how we can use this for their clinical care. They're going to bring it to us. We're not going to be the ones looking for it. And so I really do think we're going to have to develop the tools that are going to integrate these sort of information, data sources into our care. But yeah, totally. As sort of a adjacent question to that, so for the KDPI, there was a nice study that looked at replacing your race part of that with APOL1 high-risk genotype, and it showed that the APOL1 high-risk genotype performed better than the race on its own, which makes sense. Like, it's the main driver of that variable anyways. Why not use the real one? So I think it's coming.
Great. Happy to open it up to other questions. I think the logistics of how we get as many people into the fold or understanding. I think that the point that you made about patients really wanting to know, I think that we probably have underestimated people's true curiosity. Like we say, oh, you have kidney disease, and they go, okay. But like, I think you're right. I think if we said, and we think it's because of X, Y, Z, and there's a reason that people in your family had kidney disease, I think that's huge. You didn't talk at all about stones and stone disease, because that's also something that I understand is of interest, because the prevalence of stone disease in Canada is quite high, and it's associated with progression of kidney disease, and it may well have some genetic component as well. So maybe that's another thing that wasn't on your list of check marks. Wonder if you want to comment on that.
It is one of the groups that's included.
Oh.
So if you have stone disease and a family history of stones, those are people we for sure want to see at the clinic. And again, as if you have primary hyperoxaluria, that has a huge impact on your transplant journey. And your treatment journey as well. So like there's lots of ways that stones play into this as well.
Yeah, I don't know if I know Sean's on maybe a comment in terms of GN and genetic components. You sort of touched on it.
So for GN, sort of our highest risk or highest yield group to test is going to be patients with FSGS. And the classic recommendations are anyone whose onset is less than 35, is resistant to steroids, but especially if they're resistant to multi-drugs, again, increasing your risk that it's not going to be an autoimmune condition, or really anyone with a family history of glomerular disease. So especially if it's the same glomerular disease. So familial IgA has been clearly associated with collagen 4 variants. Most of our familial FSGSs are autosomal dominant, so those can run through families as well. And APOL1 is really the only one with a clear therapeutic implication right now in terms of targeted therapy. But again, I took out a slide that included all the phase 2 and phase 3 trials in Alports right now, and it literally doesn't fit on one slide. So there are exciting opportunities that are coming for these patients, and the more that we diagnose, the more we're going to have to treat.
Yeah, thanks. Any other questions that people have? I can't believe that maybe everyone's just absorbing it. It's a lot of new information. As you said, I think none of us are, we're probably not as familiar and comfortable with genetics as we ought to be for an evolving field that will really change the way that we practice and that our patients are treated. So, thank you for helping us to get up to speed, because I think that's something. And I think I speak for everyone that was really an excellent overview and very, very helpful to set the stage, and look forward a lot to both seeing more data from BC, but also seeing more data as this field emerges. Oh, I think there's one little question. Whether hypertension and family history at a young age would be part of the referral.
It is obeyed, yeah. Again, like tubular disorders causing familial hypertension are probably very under-recognized. Because we just treat them as high up hypertension, but most people are great to test.
I think it's the same sloppiness as, oh, you have kidney disease and it's probably because of diabetes, but really it's not, and the more we did biopsies or do biopsies, the more we see that's not the case. And I think it's the same thing as like, you don't, unless we think about the genetic causes, we're going to miss them. And so again, I think this is really good food for all of us to take in and think more systematically about evaluating the true etiology of kidney disease. So yeah, no, thank you very, very much for an excellent talk and really starting out this academic year in a great way. So appreciate everyone's attention and going from there. So, and there's an AI question, AI-driven tools that have shown promising predictions.
No with a but. So AI is very data hungry, as I think most of us know. And if you're trying to use like a whole genome as your data source, each whole genome is 100 gigabytes of data. So if you need 100,000 individuals with whole genome sequencing, it's just a huge amount of computing resources that we need to go into training a model for AI-based like prognostication and prediction right now. Whereas generally for a lot of these, they don't actually outperform classical prediction tools either, unless you have like massive data sets to work with. So right now there isn't a lot of actual AI tools, but people are using other sort of more standard clinical epidemiology tools. There are lots of people working on other aspects of AI. So like you have a variant, is it pathogenic? And AI is great at doing that sort of work. And so Google's really led the push for that with something called deep variant. So there's a lot of like genetics adjacent pieces that use AI, but not clinical yet.
Yet, as you said, yet. Anyways, again, thank you for stimulating a lot of thought, questions, and interest, and we will stay tuned.
Sounds great.
Thanks, everybody. Thanks for joining.